This is Jan Skowronski from Birmingham, Alabama, a land of difficult history, but also land of beautiful nature and exceptionally kind people, and land of Southern hospitality. Let me move to my presentation now. I'm going to talk about radial access for peripheral interventions. And I recall when I was speaking at the endovascular conference 4 years ago, there was just a lot of opposition from some of my colleagues, especially surgical colleagues, who were saying, well, it really doesn't make any sense. Going through the wrist to reach the leg to repair it, there are really so much easier techniques that we can adopt. Well, the world has changed over the last several years, and we actually do a lot of radial access peripheral intervention, and I would like to briefly talk about it. So the title of my presentation is Radial Access for Peripheral Interventions. Why bother? Why really go from the wrist to the leg? So there are several reasons why bother. First of all, you can much easier achieve same-day discharge for patients who had an intervention done, whether in the heart or peripheral vessels, done from the radial access. And patients really like it. There's just so many complications from the groin. Patients really like radial access. And the data is powerful that there is less bleeding if you use radial access for any type of interventions. And clinical outcomes, both in the coronaries and in the periphery, can be actually achieved on an equal level with higher patient comfort from radial access. Some of you may recall Reval coronary data showing significantly lowered the risk of bleeding. And in fact, if you go from the radial artery, the angles are just much more suitable, and it's actually easier to do interventions from the wrist on mesenteric arteries, on celiac trunk, on renal arteries, on iliac artery, and also on subclavian arteries. But sometimes we also do angiograms of the carotid arteries from radial access. I'm not a surgeon, I'm an interventional cardiologist, and I personally really dislike brachial access. I think it's really safe for the surgeons who can immediately just open it up and close it surgically. And I find the level of complications from brachial access is just unacceptable. You may recall that there is a data going back about 15 years demonstrating 6% radial artery loss after interventions from radial access. But all the data was really before radial cocktails were introduced, specifically designated and designed radial sheets were introduced, before we knew anything about patent hemostasis, and also before widespread use of ultrasound that we use for every single access, regardless of the location in the human body. So when we go through the radial artery, we actually always do an angiogram of the radial artery and the forearm, and you would be surprised how many oddities we see, radial loops and different dominance on the radial artery. So I highly recommend that you get yourself familiar with anatomy of the forearm. So if you really want to start doing peripheral interventions through radial access, the low-hanging fruit is definitely mesenteric artery and celiac trunk, but also subclavian artery, as the wires and catheters would naturally stay intraluminal even through chronic total occlusions. Renal artery is very simple to do, and we see more and more products available right now. So the companies coming up with longer shafts on their balloons. The self-expanding stents are already available on 180 centimeter shafts, and we're going to see longer. And we have dedicated radial to peripheral sheets that are 123 centimeters long, or they can be even longer. And you will see more and more products coming dedicated to radial access in the next several years. So if your first case would like to be a renal or a mesenteric, I highly recommend getting yourself familiar with a 110 centimeter MB1 guiding catheter from Medtronic. We essentially use it in 90% on mesenteric and renal interventions. And if you look at the angles, this is just so natural. This is a mesenteric artery intervention. You essentially get the catheter distal to superior mesenteric artery. You get the camera in the lateral position and you slightly pull the catheter and it will just flip. It will just pop into the opening of superior mesenteric artery. And of course, the rest is very simple. This is after the stenting. We do a lot of iliac occlusions from radial access. If you think how the plaque is structured, it is more likely to stay intraluminal on CTO occlusion of iliac artery if you go from above rather than if you go from below. It's much easier to get subintimal from the femoral axis. And this is just a picture of critical left renal artery stenosis using radial access, also with MB1 catheter. We are here just going into the left upper extremity with occlusion of subclavian artery. And here is a balloon and stent done exclusively from radial access. Just another case. This is subtotal occlusion of left fempop bypass graft. We would do it routinely from radial access. This is just another patient who had left common femoral artery and endarterectomy and has bad claudication. So we just treated this patient with a silver hawk and drug-coated balloon. So in place where I am at Cardiovascular Associates in Birmingham, Alabama, radial access is our default access for really all above SFA angiograms and interventions, with an exception of carotid stenting, but some of the angiograms we do from radial access. And by doing it, we can really achieve well over 90% same-day discharge on these patients. One thing that I do, that I know, if I know that the likelihood of intervention is very high, I actually load the patients with Plavix several days before the procedure. And we do collaborate with industry on new products coming. So in summary, radial access is growing and it's not going anywhere. And more and more products are available, and even more will be available over the next 2 years. It's definitely better for patients regarding their comfort, safety, and length of stay. And I think it gives you a competitive advantage over perhaps your other colleagues who haven't mastered that skill. So thank you very much from Birmingham, Alabama. This is our building, and I hope you enjoyed that. Thank you very much.